Hello everyone, this is a very important or must-know topic for your exams, the mesenteric artery disease. And suppose let's talk about the basic anatomy of three main vessels, three unpaired vessels uh, related to this topic. So here I've drawn the outer, and as you can see, outer is gets bifurcated here into your common iliac and into your then that common iliac artery further divides into your internal iliac and your external iliac arteries. So, but let's talk about your three main branches, unpaired branches coming out of your outer anteriorly are your celiac trunk, your superior mesenteric artery, and your inferior mesenteric artery. So this topic is specific to these three main branches, main of the outer. So celiac trunk, as we know, it arises at the level of T12 of the outer, of the vertebral body level. So here's the celiac trunk. The celiac trunk, as we know, gives three branches, main three branches. One is your left gastric, which will further get joined with your right gastric artery. But all right, the three would be left gastric, your splenic artery going towards your spleen and supplying your spleen, and your common hepatic artery. This common hepatic artery further goes and gives branches like your proper hepatic artery, your right gastric artery, and your gastroduodenal artery, and that gastroduodenal artery further would give a branch known as SPDA. Yeah, so SPDA, superior pancreatico-duodenal artery. Why I'm telling you about the SPDA? Because here I've written IPDA. So for the exam purposes, one must know SPDA is somehow a branch of a celiac trunk, whereas your IPDA is a branch of your superior mesenteric artery. So this and which further join each other. So not to confuse SPDA with IPDA. IPDA is a branch of superior mesenteric artery, and SPDA is a branch of your celiac trunk. So main thing is celiac trunk gives three branches: are common hepatic artery, your splenic artery, and your left gastric artery. Now coming few centimeters to a couple of centimeters below the celiac trunk, like around 2 centimeters, we have superior origin of superior mesenteric artery. Superior mesenteric artery arises at the level of L1 vertebral level, yeah, from the outer. So here is the superior mesenteric artery, and just at the origin of the superior mesenteric artery, here's a branch of superior mesenteric artery known as the IPDA, which I just specified, I just mentioned. And also it gives few branches like your jejunal arteries, yeah, plenty of them going towards your jejunum. So this was all about the SMA. And origin of inferior mesenteric artery is this one is the lowest. Inferior mesenteric artery is the lowest of these three main branches of the outer. It is at the level of L3, yeah, so T12, L1, L3. All right, so here we can see at the large intestine level, here's your superior mesenteric artery, same thing which I've drawn here too. So here's the superior mesenteric artery giving off three branches. Main three branches would be your middle colic, then this one would be your right colic, and this one would be your ileocolic artery. So again, middle colic, right colic, ileocolic. Further, ileocolic gives your appendicular artery branch going towards your appendix, supplying your appendix. So altogether, there are 5 branches of superior mesenteric artery. So your first one was your IPDA, inferior pancreatico-duodenal artery, which further joins with your SPDA, which I already mentioned. It's a branch of SMA, whereas SPDA is a branch of your celiac trunk. Now, and jejunal arteries. So first branch of SMA was IPDA. Then second branches would be your jejunal arteries, which I've drawn here, plenty of them coming out of your SMA. And third one will be your middle colic, then right colic, and iliocolic arteries. So 5 branches. Now, as we know, celiac trunk was supplying all your foregut, yeah, and your pancreatic area and spleen and all those areas. SMA would be supplying your jejunum, your ileum, some part, and your right-sided this large intestine, colon, yeah, large side, right side, 2/3 till here somewhere, till the splenic, or from the splenic flexure till the splenic flexure. So this is all supplied by your SMA area. Now let's go to the inferior mesenteric artery. Inferior mesenteric artery was here at the level of your origin, was at the level of L3. Here I have drawn again your inferior mesenteric artery. Inferior mesenteric artery further gives 3 branches at the level of the large intestine, just like SMA. Yeah, it gives your left colic artery, then gives your sigmoidal artery, and here it gives your superior rectal artery. Yeah, middle and the inferior rectal arteries are not part of the inferior mesenteric artery. So just the superior rectal artery. So again, inferior mesenteric artery, IMA, would give 3 branches: left colic, sigmoidal artery, and your superior rectal artery. Now, important part to know about is there's a collateral, they are joined, this SMA and the inferior IMA, they are kind of joined to each other through this marginal artery. So this part would be your marginal artery, named as marginal artery of Drummond, because, and this one is your supplying your splenic flexure area of the large intestine, this area. It is a kind of a watershed area. So it is a marginal artery is nothing. It's a connection between your SMA and your IMA. That's all. So now let's talk about the occlusive occlusion taking place in any of these arteries. Then what will happen? So there are 3 main types of your mesenteric artery occlusive disease. There are 3 types. First one is your acute mesenteric ischemia. Then is your chronic mesenteric ischemia, and one is your non-occlusive mesenteric ischemia. So what's the main 3 differences? These are the 3 types of your mesenteric arterial occlusive disease. So what happens is, in acute mesenteric ischemia, suppose what happens is, it can be either embolic or either it can be thrombotic. So in the embolic case, suppose it's an embola is formed, gets ruptured from a place and moves to somewhere, any of these branches, vessels. Then there's a severe pain, and basically what happens is, suppose a patient is suffering from has AFib, atrial fibrillation. So as we know, atrial fibrillation causes further movement of your emboli, and it can pump out the emboli from your heart, left-sided heart, and that emboli can further go either to your brain or either to your any of these vessels. And as we know, emboli, when it comes and obstruct any of these vessels, it would be a sudden severe pain. A patient would suffer with the severe abdominal pain and with the cramp. And this is about the acute mesenteric ischemia. So acute mesenteric ischemia can either be due to your emboli, or either it could be thrombotic too. And thrombotic due to patient might have atherosclerosis already. So that thrombosis get forms, and already it's so there's a narrowing kind of in that vessel is taking place, and that thrombotic event, if it happens, it happens at the original of these vessels somewhere here. Whereas emboli, if it happens, it will go further towards the periphery. But overall, acute mesenteric ischemia would be a sudden event, and it would be a severe pain, abdominal pain. Patient might have cramps too, and patient might have bloody diarrhea also. Bloody diarrhea because uh, due to emboli or the thrombus, circulation is not going towards the periphery, and there would be necrosis taking place. And as we know, necrosis and all that in the small intestine or the large intestine areas, especially the small intestine area, it would lead to bloody diarrhea, because sloughing of mucosa would be taking place, so that will cause your bloody diarrhea. So bloody diarrhea would also be a clinical presentation manifestation of the uh, AMI, acute mesenteric ischemia. And acute mesenteric ischemia, one must know, it's at the level of, or at the superior mesenteric artery. So superior mesenteric artery occlusion due to thrombus or emboli is the main culprit in the case of acute mesenteric ischemia. So remember, acute mesenteric ischemia can either be your embolic, or it can be thrombotic. Thrombotic if patient already had atherosclerosis, and emboli if suppose the patient had AFib, atrial fibrillation, so that would cause an embolic event. Yeah, then let's go about the chronic mesenteric ischemia. In chronic mesenteric ischemia, what happens is the patient would suffer. In chronic, the patient would suffer postprandial pain. And why postprandial? Suppose the patient eats and would just a few minutes or few hours after they eat, they would tell you that they're having a severe pain, and so that would cause them not to eat further, and so that's why they're anorexic, and their appetite is decreased. They would lose weight, and they would be afraid of eating food, because what happens is, in the chronic mesenteric ischemia, suppose the occlusion is somewhere here. Now this occlusion is chronic. It's not a sudden. So what happens is, there would be collaterals vessels would be formed, and those collateral vessels would help to compensate for that occlusion. But what happens is, if the patient eats, after they eat, the oxygen demand of the intestine, of the small intestine especially, it increases. And because at the time, because it's oxygen demand of that patient while they eat, after they eat, it increases, because most of the blood supply goes towards your stomach at that time. So if the blood supply and that oxygen is going towards your stomach, then your small intestine area, your large intestine area, they won't be able to deal with this event, and that's why after eating, the patient would accuse of having severe postprandial pain. Yeah, so that's the main thing about the chronic mesenteric ischemia. And it takes time. It takes time, and the pain is not sudden, because the collateral vessels have been developed in because of this chronic event. But this one happens basically because suppose the patient has already had comorbidities, or already patient had the atherosclerosis, so that's why the flow is not that much good. The flow is not flow through these vessels is not that much great. So especially in the event like after eating, they suffer with this pain. So this postprandial pain, one must remember, it comes under the topic of chronic mesenteric ischemia. And the third one, the last one, would be your non-occlusive mesenteric ischemia. In non-occlusive, as the name suggests, there would be a pain, but not all the time patient might have the pain. Here in non-occlusive mesenteric ischemia, these vessels are good. These vessels doesn't have neither thrombus, neither emboli. Just the difference in just what happens is in non-occlusive mesenteric ischemia, the flow is low. There's not that much flow going on into these vessels, either because patient might be in the ICU, and might be under the vasopressors. They might be under shock, hypovolemic shock, hemorrhagic shock, cardiogenic shock. So due to all these events, comorbidities, these patients have decreased flow going through these vessels. So although the vessels are good, but there is not that much flow, there's not that much blood going through these vessels. So that can cause pain too. Yeah. But here the main clinical manifestation would be of your acidosis, because as we know, there would be less flow that will cause your ischemia, and that ischemia would lead to your kind of anaerobic respiration, and anaerobic respiration and less oxygen would lead to your acidosis state. Yeah. So these patients would, instead of pain, they can have pain 60%, but 40% of patients, if they don't have pain, they would complain of abdominal distension. So overall, three syndromes one must know in this occlusive disease of the mesenteric vessels, and three vessels one must be familiar with. All right, that's all. Thank you.